Hello, this video aims at explaining the manifestations of right-sided heart failure and left-sided heart failure. From what I've seen online and what I've seen in person is a lot of people struggle to memorize the right-sided heart failure signs and symptoms and the left-sided heart failure signs and symptoms. And that's because they don't try to understand it, they try to memorize it. And I'm here to explain uh, I'll explain it simply so you can understand it, and then you're going to memorize it so easily after I explain it. So let's start with the cardiac cycle. This diagram is obviously not accurate. It's just simple for purposes right now. Uh, so blood, as we know, deoxygenated blood returns from the superior vena cava, inferior vena cava, and enters the right atrium, passes the tricuspid valve, enters the right ventricle, passes the pulmonary artery and the pulmonary valve as well, enters the lungs, oxygen is exchanged, pulmonary vein pumps the blood back into the left atrium, the left atrium pumps the blood through the mitral valve into the right ventricle, and into the aorta through the aortic valve. Now, let's talk about the heart sounds. What are the heart sounds? S1 and S2. The first heart sound is the lub. The second heart sound is the dub. Lub dub, lub dub, lub dub. S1, S2, S1, S2, S1, S2, S1, S2, S1, S2. S1 and S2 are the boundaries of the systole. So a lot of people think S1 and S2 are the systole. That's inaccurate to say. S1 and S2 are the boundaries. They mark the boundaries of the systole. S1 is the tricuspid and the mitral valves slamming shut. Tricuspid and mitral valves slamming shut. S2 is the pulmonary and the aortic valves slamming shut. S2 is the pulmonary and the aortic valves slamming shut. So what happens is lub causes the tricuspid and the mitral to close, to slam, preventing blood from seeping back into the atrium. This is simple bio 30 level stuff right now. And the dub is the shutting of the pulmonary valve and the aorta, preventing the blood from returning back into the ventricle, from regurgitating back into the ventricle. Simple. So like I said before, S1 and S2 are really not the systole itself, but they mark the boundaries of the systole. And we also have something called S3 and S4. And S3 and S4, unlike S1 and S2, don't mark the boundary. They are in the diastole. S3 and S4 are usually not heard in healthy patients. And they are in different parts of the diastole, like I said. S3 is in the early diastole, the ventricular filling phase. The early diastole is also known as the ventricular filling phase, so S3 is right here. And it's heard in overload/dilated ventricles. And it can be heard in athletes, which is normal because their ventricles are very powerful, and it's often described as the ventricular gallop. S4 is the late diastole, also known as the atrial systole. Noise is due to the atria contracting powerfully to push the blood into the stiff ventricle, causing it to vibrate. So the atria, they kind of contract, even though it's the diastolic phase, the filling phase, but like the atrium, they want to push the blood into the ventricles because the ventricles here have low compliance. What does that mean, low compliance? They're either stiff or fibrosed, and blood cannot really passively fall into the ventricle. So the atrium has to pump some blood, squeeze and push more blood into the ventricles. This normally does not happen. And unlike S3, at the ventricular filling phase, S4 is totally abnormal and usually never heard and almost never heard in a normal patient. It's heard in anything that causes decreased ventricular compliance, like I said, like left ventricular hypertrophy. So if the ventricle is hypertrophied, the blood cannot uh, go down easily. The left ventricular hypertrophy, hypertrophic cardiomyopathy, same idea. Aortic stenosis, okay. The aortic valve is stenosed. Stenosed means it's tight. It barely lets in blood. So what's going to happen is there's going to be blood pooling here, and the compliance is not going to be good. So the atria has to push the blood into the right ventricle. I mean the left ventricle. This is supposed to be left ventricle. I accidentally put right. So this is right atrium, right ventricle, left atrium, left ventricle, left side, right side. It's also known as the atrial gallop. So we said S3, ventricular gallop. S4 is the atrial gallop. Now let's talk about the names of uh, the phase itself. S1 is also known as the isovolumetric contraction phase. S2 is also known as the isovolumetric relaxation phase. And the systole, like I said, itself is in between the S1 and S2. The systole is known as the ventricular ejection phase. The heartbeat itself, ejects the blood. And ejection systolic murmurs occur here, obviously, because it's during the ejection. S1, S2, like I said, systole is in between. Systole is approximately 0.3 seconds or 1/3 of the cardiac cycle. Between we have the diastole. It's 0.5 seconds. Oh, oops. What's going on? Okay, it's 0.5 seconds and it's approximately 2/3 of the cardiac cycle. We said S3 is also known as the ventricular filling phase. And S4 is also known as the atrial systole, like I said, because of the contraction of the atrium. And then this cycle starts again with S1 and then systole, obviously. Okay, now let's talk about manifestations of low cardiac output. Low cardiac output is usually low cardiac output usually causes decreased systemic perfusion, which basically means decreased blood flow to the rest of the body. Okay, so if we use our brain a bit and think, what does that mean? If we have less blood going to the brain, we have dizziness, syncope, confusion. If we have less blood going to the heart, we have possibly angina due to myocardial infarction, due to decreased oxygenation of the cardiac muscles, exercise intolerance, obviously, worsening heart failure if the patient has heart failure. If decreased perfusion to the kidneys, we have decreased blood filtration, which decreases urine, which is also known as oliguria. Decreased blood in the skin causes clammy extremities and peripheral cyanosis. Decrease in the muscle causes fatigue and decreased exercise capacity. There's also decrease in blood pressure and pulse. We're going to have obviously low systolic blood pressure because it's related to the stroke volume, as we talked about right here. Right ventricle stroke volume pumps the blood. This is the systolic blood pressure. Okay, and weak pulse and increased heart rate because of the low systolic blood pressure obviously causes weak pulse, and plus or minus increase of the heart rate. The heart has to work harder because of the lack of perfusion. So low cardiac output causes systemic perfusion, no systemic perfusion. Now let's talk about right-sided heart failure and the manifestations of systemic congestion. So whenever you're thinking about right-sided heart failure, sorry about that, Okay, let's think about it logically. This is the right side of the heart, right atrium, right ventricle. If this side cannot pump blood, what's going to happen? Well, blood's going to stagnate here. It's not going to really go to the lung to get oxygenated due to weak contraction. What's going to happen? Well, what about the blood that's coming from the superior and inferior vena cava? Uh, it's not going to flow effectively, and this is going to cause stagnation in the inferior and superior vena cava and the rest of the body, which is going to cause manifestations of systemic congestion. So let's talk about the superior vena cava. If the blood is not going to be able to flow good into the right atrium, we're going to have increased jugular venous pressure. The jugular vein cannot drain as easily into the superior vena cava. And then we have also right-sided pleural effusion, same idea. Why right-sided? Usually because on the right side, there's possibly fluid from the liver, because the liver is also congested. We also have a larger right hemithorax, and lymph drainage. The lymph drainage in general favors the right side, so it's usually right-sided. For inferior vena cava, we have peripheral pitting edema, like it could start at ankles and go all the way to sacral. Obviously because of the water and the fluid due to poor venous drainage. Ascites, same idea. Poor venous drainage, poor causes systemic congestion, which causes ascites. Congestive hepatomegaly, the patient will have a tender liver, so typically right hypochondrial pain, and in the long term, he or she might even develop cardiac cirrhosis after years and years. This usually does not happen. GIT congestion due to poor drainage of the fluid. So we're going to have anorexia, the patient doesn't really want to eat, nausea, and dyspepsia. Weight gain due to fluid retention, this is obvious, and also the edema. Okay, so now we know basically what you need to know and what you need to think about when you think about right-sided heart failure is think about the systemic congestion that it will cause, and you will know automatically pretty much all the clinical manifestations. Now let's talk about right ventricular hypertrophy. Right ventricular hypertrophy is usually prior to right-sided heart failure, so you need to recognize the signs of the right ventricular hypertrophy. The heart, to compensate the increased blood flow to the right ventricle, it's going to hypertrophy. It's going to try to work hard, but eventually this is going to lead to heart failure. So this is why it's important to pay attention for the signs of right ventricular hypertrophy. Okay, I know this drawing looks a little bit messy and complicated. I'm sorry about that. This is the sternum right here. And this is the diaphragm. And I want to explain why. The reason I drew them is how the signs are related to them. So number one, left parasternal pulsations. You're going to feel pulsations clinically here. Why is that? Well, if you look at the right ventricle, anatomically, when it hypertrophies, especially, it's usually seated on the left side anyways, so you're going to feel the pulsations here, more powerful pulsations. Second, epigastric pulsations. Why epigastric? Well, if we look at the diaphragm, the right ventricle sits on the diaphragm, especially when enlarged, and it's gonna transmit the beat to the epigastric area, and you're gonna feel it clinically when you examine the patient using this method. I forgot what it's called, but when you basically place your fingers along the on the epigastrium of the patient, you should feel the pulsations. 3. The apex is diffused and shifted laterally. Laterally only. It's shifted to the left. It's not shifted down. Pay attention to that because in the left ventricular hypertrophy, it's shifted down and out, but in right ventricular hypertrophy, it's only shifted laterally because it grows. This grows and it pushes the left ventricle outside laterally. So as we know, the left ventricle is normally fifth intercostal space, midclavicular line. This would probably not be midclavicular line anymore. It'd be a little bit deviated. Okay, what else? 4, I've increased jugular venous pressure. Obviously, poor drainage, it's going to increase the jugular venous pressure. It can be seen if you put the patient in a 45-degree angle and you ask him to turn to the left side because it will show the jugular vein more clearly. You'll see the pulsations usually. 5, attenuated P2. P2 basically is the pulmonary area right here over the pulmonary valve. When you hear it with the when you auscultate it, it's going to be strong and powerful. You're going to hear it louder than other areas. 6, S4 and S3 might both be present. Like I said here, this is S4. Atrium wants to push the blood into the right ventricle. S3 may be present, but it also may be absent. 7, and this is the last point, but it's an important point. Well, it's not the last, it's second last. There's tricuspid regurg, functional. It's functional. Okay, so how does a regurg happen? I'm confused. Well, the heart usually doesn't only hypertrophy, but it also dilates. Okay, once the heart dilates here and here and here, dilates everywhere basically. This causes the tricuspid valves here to stretch. The leaflets of the valve stretches, which causes poor closure. It's not able to close properly anymore to stop the blood from coming back down. And this causes regurg. So the blood, instead of being trapped up in the atrium before the ventricle pumps, it leaks slowly, and this can be heard over the tricuspid area. All right, well, that was the right-sided heart failure manifestations and the right-sided ventricular hypertrophy. Both very important clinically. You need to recognize them as a doctor, especially as a cardiologist. Okay, now let's talk about left-sided heart failure manifestations of pulmonary congestion. So when you think of left-sided heart failure, what do you think of? Basically, the left ventricle cannot pump blood to the aorta anymore, to the rest of the body. So what happens? Well, sorry about that. Left-sided heart failure is due to manifestations of pulmonary congestion. When we said earlier that the left ventricle cannot pump anymore, blood is going to accumulate in the lungs, the oxygenated blood, because it's going to try to dump into the atrium. Let me try to find the diagram. Sorry, one sec. Yeah, here. The blood from the lung, imagine this is the lung here, is going to try to dump into the atrium, but the atrium can't even dump into the ventricle because of all the blood in the ventricle, because the left ventricle is overloaded. It cannot pump the blood to the rest of the body. So this blood ends up stagnating into the lungs. So whenever you think of left-sided heart failure, manifestations are of the pulmonary congestion because the blood pools in the lungs, as we said. Heart can't effectively pump out oxygenated blood, lung congestion. So we have dyspnea, which is difficulty breathing, and it's usually exertional. This is a high yield question. Orthopnea. What is orthopnea? It's dyspnea when lying flat. And why does this happen? Because we have increased venous return to the thorax and the lung, increased pulmonary venous pressure, fluid enters the interstitium, and it causes dyspnea. And then we also have paroxysmal nocturnal dyspnea, which is a type of orthopnea. It's due to the increased venous return that happens when you sleep and decreased heart rate and breathing in your sleep, and this causes sudden severe dyspnea. This combination is deadly. The patient wakes up feeling like he was about to choke to death. He sits up, usually he or she sits up, goes for a drink, sits by the window, and a lot of them they end up sleeping in semi-sitting positions because it's so uncomfortable to just like lie down. Cardiac asthma, it's basically another symptom. It's exertional cough plus nocturnal wheezes, and these exertional coughs and nocturnal wheezes are due to pulmonary congestion, and which causes airway edema, causes bronchoconstriction, reflexive bronchoconstriction. This causes the wheezes and the exertional cough. Hemoptysis from repeated exertional coughs, pink frothy sputum in acute severe pulmonary edema, pleural effusion, usually bilateral, if unilateral, also right-sided for the same reason we spoke about before, bilateral basal cryptations due to fluid congestion, recurrent chest infections in chronic cases due to stagnant fluid. So when you're thinking of left-sided heart failure, you basically want to think of pulmonary congestion. Okay, signs of left ventricular hypertrophy. Number one, apex is shifted outwards and downwards. Okay, remember the right ventricle is only shifted outwards. The apex is shifted outwards and downwards. So it'd probably be instead of fifth intercostal space, midclavicular line, it'd probably be like sixth intercostal space, a little bit out of the midclavicular line. Two, apex B is localized, heavy, and sustained. This apex, the apex of the heart is this. It beats hard because it's hypertrophy. Has a more powerful contraction. All right, third, attenuated A2 due to strong stroke volume. So, and not strong stroke volume, sorry. It'd be the valves are closing even harder to stop more of the blood from returning due to the higher stroke volume at the end. And it's heard over the aortic area. Number four, S4 atrial systole is heard due to the fact that this atrium is desperate to push more blood into the left ventricle, but this ventricle is hypertrophied and is not compliant to the blood. It does not easily take blood. Okay, number five, mitral regurg due to, like we said, the enlargement of the heart, which causes the widening of this space, in all the spaces, but this is the important space, stretches the valve leaflets. It can't close properly, which causes functional mitral regurg. Very important, and it's often heard on the mitral area. And not with the, I believe it's heard with the cone, not the diaphragm. So be careful when you auscultate. Let's see. Number six is systemic hypertension, basically due to the stroke, strong stroke volume. So this ventricle is hypertrophied and pumps out the blood with great force, which is going to cause hypertension. Very dangerous. And like we said, due to stagnation of blood in the lungs, symptoms of pulmonary congestion may be present. And that's it. I hope that helped, and I certainly found this method easier to memorize than just reading the textbook over and over and not connecting what I'm reading. I hope it was helpful. Thank you.